We're up to 120, so that is absolutely fantastic in terms of the number of people who've made it. And I suspect that a few people will be joining us. But in order to ensure that we've got maximum time for our three fabulous presentations, I will start. I'm Liddy Goyder. I'm a member of the First Fusion team, and I have the great honour and privilege of introducing the speakers and chairing this afternoon's first seminar. The topic of this afternoon's seminar is public health interventions with children and young people. And as you will have seen, we've got three great presentations which basically span from a intervention with parents and babies to one with children and one with young people and young adults. So right across the span of the children and young people 0 to 25, and across the UK. So presentations from both colleagues in England and in Wales. And just to remind everybody, this was in the reminder email, the seminar is being recorded and your camera and mic have been disabled. So if you have any questions or any comments, feel very free to put them into the chat. What we'll do is we will try and pick up a couple of questions after each presentation and then hopefully have some general discussion at the end. So most of you may have already come across the first programme, which is funded by the National Institute for Health and Care Research. And essentially the first programme is 8 academic teams that then work with organisations, both third sector and local government, that commission and deliver public health interventions right across the UK. And the overall rationale is that if we evaluate innovative practice, we can share the learning, we can inform policy and practice, and of course have a real impact on population health and inequalities. And something that I wanted to flag up, and I will put this slide up at the end of this afternoon's seminar as well, is that the call for new evaluations is currently open with a deadline of the 17th of June. So don't panic if either during this afternoon or after today's seminars you think actually you or your colleagues are aware of innovative public health programs, policies that you think would fit with the remit of the first programme. You've still got a month to get your expression of interest in. So moving on to the programme for today, and I would just flag up that as well as the presentations you'll see today, there's quite a lot of other resources on the first website and on the page for this particular seminar. I draw your attention to the fact that there is a blog. It's called From Questions to Cartoons, and it's all about the implementation findings from an evaluation of school streets in Newcastle. There's also a couple of animations linked to 2 of today's presentation, so that if you want to look at them after this afternoon, you will find them on the website. But you will also find on the first website an absolutely huge resource of the outputs from the evaluations that have been done across a very wide range of different public health interventions. So it's very often a good place to go when either in your own day job or your colleagues ask, where can we find research, on particular public health evaluations or information about what's been done and evaluated in other parts of the UK. Today, we're starting off in Nottinghamshire and then moving to Wales, to Cardiff and the Vale of Glamorgan, and then after the break going to central Bedfordshire. In terms of the timing for today, we've got an hour and a half. So the one thing that I am going to suggest is that we do have a break after the first 2 presentations, and we'll probably break about 9:45 to 3, but we do come back by 3 o'clock to ensure that we have plenty of time for the third presentation. So if you want to make absolutely sure that you don't miss the third presentation, make sure you are back by 3. But in the meantime, we'll kick off, and it's my great pleasure to introduce Nick Woodrow, who's my Sheffield and First Fusion colleague, who is going to talk about the Nottinghamshire Healthy Families Programme Parent-Infant Relationship Initiative. And over to you.
Thanks, Lindsay. I'll just share my screen, make sure everyone can see. Yeah, so as Lindsay said, I'm Nick Woodrow. I'm a research fellow based at Sheffield University, and I work as a researcher for First Fusion. And I'm going to talk today about one of our research projects, which is the Nottinghamshire Healthy Families Programme's Parent-Infant Relationship Initiative, or PIRI. So we've done an evaluation of the PIRI, and I've got quite a lot to cover today, so I'm going to try and speed through things, and I'll do my best to cover everything. So I'll start off with just a bit of a background and explanation about the PIRI, and then I'll talk about our evaluation methods and our findings. So these are just a couple of infographics from the Parent Infant Foundation, and these talk about the importance of the first 1,001 days of a baby's life and the importance of good relationships between babies and parents for supporting development. So there's lots of research out now showing how the first 1,001 days are a critical and crucial period of a child's life for the development, and how parents who are able to identify and respond to the baby's needs in an appropriate and timely way can support early development. And there's a growing evidence base showing the value and the effectiveness and the efficacy of parenting support interventions, and how these can improve the health and well-being for young children. So what's important for us to look at is what makes such interventions effective, what makes them meaningful for parents, what makes parents engage and stay engaged. So just a bit of background about the PIRI and how it was developed. In the UK, health visitors have got to have at least 5 visits with family mandated kind of visits with families with babies at key stages of their development from birth to around 2.5 years old. And these visits are designed to monitor babies' development and well-being, and also provide support and advice to parents. Now, in the aftermath of COVID-19 and the impact this had on babies' health and well-being and their development, Nottinghamshire County Council identified an opportunity to increase support for parent-infant relationships through the introduction of a bespoke parent-infant relationship team. So they developed and piloted the PIRI. Now, I'll quickly try and explain what the PIRI is. We do, and we have developed a nice animation with the PIRI team, which does this. It explains the PIRI, what it does. It explains the research. But I'm not brave enough to try and play it live. My kind of luck with technology, things always go wrong. So you've got me talking about it instead. But the information is, and the video is available on our project website, and I'll put the link in the chat afterwards if anyone's interested in watching that. But essentially, the PIRI. It aims to support parents to strengthen the relationships with the baby. It aims to develop and improve bonding, understanding and connection between parents and babies. So the PIRI team, or during the evaluation, the PIRI team comprised of 2 parent-infant relationship practitioners. So these were specialist health visitors. So the PIRI team or the PIRI practitioners sit within the health visitor service. Families are identified and referred to the PIRI team by health visitors, and this is based on the clinical judgment of the health visitors, and also on the completion of an EMBO assessment during one of the initial health visitor visits. So parents need to consent to the referral, and then health visitors are able to make a referral on their behalf. The PIRI team then review the referrals, and if it's accepted, they undertake a full assessment with the family. And from this assessment, if it's deemed suitable for the family, and if parents consent, then support can be offered. So the PIRI team provide up to 6 different support sessions over 6 to 12 weeks, and the support draws on a menu of interventions, with the sessions being individually tailored and kind of co-designed and co-selected with parents depending upon their specific needs. So this can include things around responsive parenting or how to strengthen the parent-infant relationship. And support from the PIRI team is typically delivered face-to-face at parents' homes by one practitioner all the way through the support. So during the pilot of the PIRI team applied for the initiative to be evaluated, and they worked with my team at First Fusion to do this. Now the online evaluation report that we've got covers the evaluation aims and the methods in detail, but essentially we wanted to understand if the PIRI was kind of seen as an acceptable and helpful approach for the perspective of parents and practitioners, and if it was improving parent-infant relationships. And to do this, we undertook a mixed methods evaluation. We spoke to parents who would been receiving support from the PIRI team. We spoke to practitioners who were involved in the PIRI in some way. This included the kind of PIRI practitioners and also health visitors who made the initial referrals. And we also looked at some of the routinely collected service outcome data that the PIRI team had access to. So I'll go over some of the key findings now, but as I've said, there's much more detail available in his project report. But essentially, the PIRI was perceived as extremely positive and provided various benefits and valued support to parents. These are some of the kind of key themes that parents, or the key things that parents spoke about. I'll not go through them all, but essentially they talk about how the PIRI support helped them in kind of improve the bonding and the connection with the babies, and generally just improved the relationships with the babies. So the interview data was also reflected in the kind of service outcome data that we had access to. And this graph here shows some of the parents' reported outcomes. So they do a pre and a post survey, and this shows from the data that we had around 80% of parents reported improvements interacting with the babies, and around 90% connecting with the babies. So the kind of quant and the qual data we had kind of were complementary, and generally overall just showed a kind of positive impacts. Now this graph shows data comparing ASQ scores for babies at the 12-month review for a cohort of children who received PIRI support, and comparing to a group of children or children across Nottinghamshire County over the same period. So the ASQ is the ages and stages questionnaire, and this looks at kind of babies' learning development and behaviour. So based on the data we had, we found a significantly greater proportion of children who received PIRI support were achieving the ASQ milestones at the 12-month review, compared to children across Nottinghamshire County more generally who received usual support. So around 95% of PIRI babies were achieving the milestones, compared to around 85% of babies across Nottinghamshire County more generally. So again, this highlights the effectiveness of the PIRI, highlights the effectiveness of parent-infant relationship interventions, and also the impact the PIRI is having on babies' development. When we're looking at what key things were valued by parents, what made the support effective for them, I think a lot of the findings can seem like common sense, but these were really important to the parents, and they were consistently and continually mentioned by parents as being things that the PIRI team did really well. And this was kind of comparing the PIRI support to other support and other services that they've been involved in. And these are the kind of key reasons why the parents felt that PIRI support worked so well. So the parents described support as being accessible, and this was in terms of the team being easy to reach and contact, accommodating to the needs, flexible in reorganising and organising support. The fact that support was delivered at home was kind of crucial to parents' engagement. And the parents also spoke about how the team took a family perspective, and not just a mum and baby perspective, but also tried to include like all parents in the support and accommodate appointments and sessions when all parents could be involved, and that was kind of really important for the families that took part. The parents described support as flexible and tailored, so tailored in terms of how it met their individual needs. So the parents felt involved in the design of the support and in the selecting of the support, and this got a kind of level of buy-in from the parents that they felt listened to, they felt valued. And again, this was seen as different from other services where support was kind of done to parents, where this felt like it was done with them. And in terms of the flexibility, which was kind of mentioned a lot of times, the way that the support was structured allowed for adaptability to emerging issues. It wasn't like a set and rigid program that was decided on at the start and followed all the way through. It was flexible and adaptive to the changing needs of parents and the changing needs of babies, which was really kind of really valued. And the parents again spoke about the support being well paced and easy to understand. And again, this goes back to the flexible structure, which allowed for things to be revisited. It allowed for concepts to be recovered, and this allowed the parents to kind of better understand and better engage with the support. Now, what was kind of really crucial in supporting engagement for parents were the practitioners' knowledge, skills, but approaches. So the parents kind of continually spoke about how the practitioners were supportive, kind, caring, compassionate, non-judgmental, and this kind of fostered really good relationships between the parents and the practitioners, and this kind of got engagement and got investment in the sessions. And because of the nature of the topic, this was really important in parents feeling confident to open up and discuss the issues that we're having and to not feel stigmatized or to not feel judged. Now I'll talk a little bit about some of the kind of implementation challenges that we found. So from the parents we spoke to, there was a reported mixed initial understanding about the PURI. So from the referral that health visitors made, due to a lack of clear explanation from them, some were a bit unsure about what the PURI could actually do. And when we spoke to the health visitors, they also kind of showed that they had their own challenges around understanding of the PURI and awareness of the PURI. So several health visitors reported lacking kind of specific knowledge about what kind of sessions could be offered, for example. So this lack of knowledge made it difficult for the health visitors to provide clear and consistent information to parents. So the health visitors spoke about how when they have got a limited understanding, the struggle to identify which parents were appropriate to refer, and the struggle to explain to parents what the PURI was and what it could exactly do for them and the babies. And then they suggested that if parents were unsure, they were less likely to engage. So this kind of suggested like a missed need in some groups. The health visitors spoke about their kind of capacity and how this impacted identification and need in families. So they spoke about how they had a limited number of contacts with families, they had a limited amount of contact time and a large amount of tasks to do during this time. So they found it really hard to identify need and make the referrals. And they also spoke about the challenges they found around discussing sensitive topics around parent-infant relationship difficulties with parents, due to a concern around a relationship breakdown between the health visitors and the families. So the health visitors weren't scared about having these conversations, they were just unsure about how to do them effectively with the limited time that they had. And finally, the PURI practitioners themselves, they spoke about their own caseload. So there were only two practitioners, and they spent a significant amount of time covering the large geographical area where they had to provide support, and also spent a large amount of time trying to engage and promote the service to health visiting teams. So from these results, we suggested some kind of key recommendations for the PURI service moving forward. Now, as we found, kind of the PURI was effective and was seemed to be working in terms of supporting parents, and seemed to be supporting parent-infant relationships. We suggested it was really important to kind of maintain this. It was important to maintain the current value and benefits and to make sure these were highlighted to potential parents. So as parents valued the kind of one-to-one support that the PURI team provided, that the support was delivered at home, it was consistently delivered by the same compassionate staff member, that support was tailored and adaptive and supportive and flexible, and how they were kind of parents were involved and support was kind of co-designed around their needs. These things were kind of really important and should be maintained and highlighted. But staff need to have the time and the skills to be able to build these relationships and to be able to offer this kind of flexible and personalised service. And it's really important that they did this because this is what had the significant impact. This is what the parents found to be effective. So yeah, to facilitate engagement and maybe uptake from parents, I think it's important that to advertise and promote these valued features, PURI support when presenting the service to parents, and also to highlight the benefits that support can have for both parents and babies. So we suggested that it's really important for kind of the key referral sources, the health visitors, to be knowledgeable and informed about the PIRI and the specific support that it can offer, so they can provide these clear and consistent messages. So we suggested additional training for health visitors around the specifics of PIRI support, and also how to introduce and have conversations around parent-infant relationship difficulties. Now, the PIRI team were already doing this, but due to their limited capacity, they weren't doing it, I suppose, as much and as effectively as they would like. And then we also suggested maybe embedding kind of a PIRI practitioner within the different health visiting teams to improve service promotion and awareness. And finally, suggested the importance of continuing to collect data and identify different data sources to identify long-term impacts and outcomes. So, for instance, monitoring the ASQ outcomes at the kind of second year review to see if the positive impacts from the first year are continued and carried forward. And we also suggested that the team could monitor the demographics of the families that they support at each stage, so at the initial referral, at the assessment, at completion, or at disengagement, to see if there's different groups who are accessing support, and if there's work needs to be done to better target and better support some groups. So I've rushed through all the slides there. There's a bit of time for questions in a moment, but I'd just first like to invite Helena, who was one of the evaluation members and commissioner for the PIRI service, just to talk about some of her reflections from their involvement in the evaluation. I think she's
I'm here. Thank
hello.
you very much.
No problem.
Thank you for sharing. Yeah, so hi, I'm Helena Cripps. I'm a Senior Public Health and Commissioning Manager based in Public Health in Nottinghamshire County Council. And really, we're absolutely delighted with the findings from the evaluation. It's brilliant to have the evidence that this intervention has made a difference. For me, for us, I think the qualitative feedback from parents was overwhelmingly positive about this intervention. It gave us a real richness, I suppose, in terms of understanding the impact of the intervention, but also the subtleties of why it was successful for those parents and how it needed to be delivered to support parents to engage in that in the best way. And also the feedback we had along the way from professionals. So, for example, all the feedback Nick shared from the health visitors about how challenging it was initially to implement really helped to shape the pilot as we went through, so we could improve their understanding of the intervention and help them to support and identify the right parents for it. But to be completely honest, from a commissioning perspective, for us, it was the quantitative data that was really key. Being able to see a positive change in pre and post outcome measures, and also the added value of seeing that positive difference in a child's social or an infant's social and emotional score at 12 months through their ages and stages questionnaire was absolutely brilliant. And I think because of the evaluation overall and those findings, it's meant that we have been able to continue the intervention because we've got that evidence that it's had a positive impact on outcomes, and that really helps us to prioritise even within the scope of a commissioned service. So our health visiting service is already a commissioned service, but it enables us to prove impact and continue that intervention when there are lots of pressures and demands on their times. So yeah, it's our hope that in future we'll be able to increase the numbers of families that benefit from the intervention and continue to grow the intervention really. And we've been able to make some changes to how it's delivered based on the findings and the recommendations that Nick shared. But no, overall, thrilled with the positive evaluation, and it was great to be part of the process. And what was particularly nice was seeing the team. So it's a really small team. It's 2 specialist health visitors and their manager who deliver the intervention, and it was great for them to be so actively involved in the evaluation because they were so actively involved in designing the intervention. So yeah, thank you very much.
Great. Thank you so much, Helena, for joining us and sharing your experience. And thank you very much, Nick, for compressing, a lot of information about the evaluation into a short space of time, and we've got quite a few questions and comments in the chat now. One thing I'll just highlight for particularly maybe for Anita and Claire, because I'm aware that we're not going to be able to cover everything, and that Nick didn't talk in any detail about the methods or the sample really of the evaluation. That information is all in the main report, and will hopefully be in a peer-reviewed paper in due course. So I'd kind of encourage people who are particularly interested in the detail, both of the intervention and of the methods of the evaluation, to go and have a look at that report. But I think we have got a couple of minutes, Nick and Helena, if you can comment on one or two of these questions. So there's a question from Shagufta about maybe the possible factors why there was a decrease here, why the intervention made a specific difference in obviously some of the dimensions. There's also a question about generalizability and whether the animation might be useful elsewhere. And there's a question about potentially replicating things, which is one for Helena. So maybe we can cover those before we move on quickly, Nick, starting with the one about if we have any insights into the basically the findings you showed in that nice graph where some of those things had really changed significantly.
Yeah, so I think it talks about the ones that are decreasing. So the ones that are decreasing linked to support networks, relationship, physical health, and mental and emotional well-being. So we didn't really have scope to explore the reasons why that is, but they were kind of side outcomes I think the PURI team were interested in measuring. And Helena, you might be able to answer better.
No, I was just going to say, I think the specialist health visitors feel that it was increased awareness of the implication of increased awareness of that self of that state, your self states, if you like. So increased awareness that actually maybe the support networks weren't as good as you thought they were, or your physical health wasn't in the great place that you thought it was at the beginning of the intervention. So yeah.
Yeah, thank you. So look, is the animation suitable for other areas? I think it was designed for Nottinghamshire area to kind of better promote and advertise the PURI, but there is aspects with it that may be kind of more broadly relevant in terms of the implication of the findings. But I think it is specific about the PURI team and what the PURI team is and what the PURI team can do.
Yes, I guess that kind of links to the question about whether there's potential to roll out this programme more widely, or any plans to.
In Nottinghamshire? Yeah.
Well, yes, although obviously I'd be interested if anybody wants to put information in the chat about other areas that might be doing similar things, because we're obviously not going to have time to talk about it, but that's worth sharing.
I think there are examples of other parts of the country doing similar things. In Nottinghamshire, we've changed the way it's delivered slightly. So part of the evaluation finding recognised we're a really large county, and actually 2 whole-time equivalent practitioners, it was really challenging for them to deliver. So although we've not yet been able to increase the overall capacity for the service, instead of it being the whole job of 2 practitioners, it's now part of the role of a number of extra specialist health or health visitors and specialist health visitors across the county. So we're trying to move in the right direction of increasing that capacity, and we very much hope that in the future we'll be able to grow the intervention across Nottinghamshire. But the team are also really happy to share the details of the offer and how they deliver it, if that's helpful for other areas.
Yeah, and I think just quickly before we move on, Lydia, I think we know that these interventions do work, and I think what was interesting from this evaluation is we looked at some of the specific features and the reasons why they can be useful and effective. So these are the things that can be carried forward, that can be implemented and integrated to other services that are running something similar. And so it wasn't just about the PURI, it was about the specific things that the PURI practitioners are doing and the PURI team are doing that kind of make it more effective.
Yeah, absolutely. I mean, I think I suspect lots that resonated with other people in the audience here. So, as always, it's always a shame to have to move on, but allow us to do justice to our other two presentations. Thank you very much, Nick. Thank you so much, Helena. And we're going to move on to our next presentation, which is from our colleague Samantha Garay from First Insight, who is going to talk to us about the evaluation of a healthier advertising intervention in Cardiff and the Vale of Glamorgan. So I'll hand over to you, Samantha. Thanks.
Cool. So I'm hoping you can all see my slides now. It's always a bit of a worry at these things, if you can or not, but just let me know if you can't. So I'm Sam. I'm part of the First Insight team, which is a collaboration between Cardiff and Bristol universities. I'm going to be talking about the evaluation that concluded in December, which was looking at healthier advertising in Cardiff and the Vale. And for this talk, I'm going to be focusing on children and young people's perceptions of this advertising restriction, or planned advertising restriction anyway. So, oh, they're going to let me change. There we go. So the UK is projected to be Europe's most obese country by 2030. Currently, 35% of adults are recorded as obese, and 1/3 of children are considered to be overweight or obese. Advertising is recognised as influential driver of behaviours and eating patterns, and this is particularly true of advertising of products that are considered to be HFSS or high-fat sugar salt products. Whilst wider HFSS policies have been implemented and are planned within the UK, such as the England's National 9 PM watershed on TV, the Transport for London HFSS restriction on their sites, as well as the planned HFSS restrictions in supermarkets in Wales, there are currently no regulations of HFSS food and drink advertising across council-owned sites outside in Wales. So, as part of wider efforts to tackle obesity and to improve healthy weight in the population in Wales, work is currently being undertaken by teams to implement a policy to restrict the advertising of HFSS food and drink products on council-owned and contracted sites, such as bus stops. So, this policy is planned for 2 regions in Wales, and that is Cardiff and the Vale of Glamorgan, and this is particular work that we were evaluating. So about the evaluation, as with all FIRST projects, this was co-produced with the evaluation teams, and in this case, this was members of Cardiff and Vale University Health Board, Cardiff Council and Vale of Glamorgan Council, and this was a 15-month study, which, as I said, concluded in December. We aim to evaluate in this study a mixture of things. So first of all, there was public perceptions of HFSS advertising and the planned policy changes. There was also the barriers and facilitators to implementing the policy, as well as finally the potential perceived impact of the policy implementation. And in this particular talk, I'm going to be focusing on aims 1 and 3, as those are the ones that relate to children and young people. So this was a mixed methods evaluation involving multiple components. We invited residents aged 16 plus across the 2 regions to complete a survey, and this was focused on their awareness and the influence of HFSS advertising on them in their local area. We also, from this, then conducted follow-up in-depth interviews with a sample of residents who completed the survey to further explore their views. We also conducted stakeholder interviews with a range of people who were involved in the policy process in various ways, and this included council, health board and advertising representatives, as well as practitioners and policymakers. And we also incorporated data that had been previously collected by the local authorities during 4 waves of a bus stop and mapping exercise that was conducted by our partners in the local authorities. And we helped with collecting some of this data during our evaluation. But the part that actually relates to this talk is the school focus groups that we conducted across schools in the areas. So we made sure that public involvement was embedded throughout the study, and this was in various parts. So we had our main PPI representative, who was Sian Hardin, who is a retired teacher from Wales. Sian was involved from the very start of the evaluation and was involved in all study stages, providing invaluable input as a member of our study management group. We also conducted several sessions with members of a local youth council group, which actually informed the focus of our study, such as the questions and our aims, as well as the design and the development of study materials. And finally, we also worked with a group of primary school pupils to help inform the study materials, also acting as a pilot for us and providing feedback on the topic guide for the children. In terms of participation, as I mentioned, we invited schools across Cardiff and Vale of Glamorgan to take part. Initially, we recruited on the basis of how close they were to bus stop advertising. However, we had to expand this when we hit some recruitment issues. In total, we were able to conduct 7 focus groups across the 7 schools, and this was in 5 primary schools and 2 secondary schools. And in total, 49 young people aged 9 to 14 years participated in our focus groups. We found that there was actually a really high awareness of advertising that they perceived to be HFSS. They were aware of advertising close to their home, on their way to school, on busy roads, and especially in the town centres, with less advertising typically noted in immediate residential areas where they lived. When we asked about their awareness of HFSS versus healthier advertisements, we found that overwhelmingly they were aware of HFSS adverts, although a couple did mention healthier adverts by a minority of pupils. They were also able to easily describe advert content, and this included stuff such as deals, the price of the products, new product promotions and brands, as well as adverts if they were endorsed by famous people, such as footballers, or involved event sponsorship. I believe last year it might have been a big World Cup or football event that was going on, from my memory, and also if they involved competitions of some sort. And this picture we've got next to us, so as part of the focus groups of primary pupils, we actually asked them to draw us an advert that they recognised, or they could remember from what they had seen. And this is one of the examples they gave us, which is an example of a McDonald's advert and a deal they actually had on at the time. And on the next slide as well, there'll be another example of this. However, we did also find that they were exposed to advertising on a mixture of other media, such as radio, TV, online, and in particular on social media, where there was high awareness of stuff they would come across, and even also on YouTube. When we asked them about what the influences advertising on their behaviours, in general, participants reported that seeing advertising they considered to be HFSS made them really want to try those products. If they saw them perhaps on their way home from school, they'd be particularly keen to actually go buy them. A few did believe that adverts had no influence on them, but later in our conversations, it kind of came across that actually, from what they were telling us, it did perhaps subconsciously have some sort of influence on them. Young people, or those given their age who actually had more autonomy over what they bought and what they ate, they would tell us that they would quite often buy HFSS products that they had seen advertised, and particularly true if they've been into the town centre or a meeting with friends. And many children who are younger and obviously don't have autonomy over their purchasing, but they would report asking their parents for advertised HFSS products that they had seen. Although it was frequently highlighted by others that whilst they wanted to ask for these products, they knew they didn't, as they knew the answer from their parents would be no. So even if they wanted to, they didn't do so. Finally, we also asked them about what they felt could be the impacts of this policy change, the restriction that might be brought in. And in general, children and young people were very positive towards a HFSS policy change to restrict this unhealthy advertising. There's only a very small minority believing that some unhealthy adverts should still be allowed. There's some of them actually quite like seeing the adverts around. They recognise both positive and negative potential impacts of the PAN policy. In terms of negative impacts, children and young people felt that some people might not like it. They might not like these changes that could come in, and they might actually like seeing these adverts. They also felt that fast food outlets might not be happy by these changes. They also felt that it might cause fast food outlets to lose money, and that people might actually become too healthy and actually lose too much weight from these changes in the policy. In terms of positive impacts, they felt that people would actually eat healthier foods, as they wouldn't be so driven to buy the foods that they had seen on these adverts. So there'd be less temptation to eat these HFSS foods. They also thought that perhaps it would improve fitness and actually increase the revenue for businesses selling the healthier foods. And they also felt that there would actually be less pressure on parents from them to try and buy these expensive HFSS foods. And this was quite interesting, as they did recognise that there was this price value associated with these products. And finally, longer term, the children and young people felt that there could actually be a reduction in health conditions such as diabetes and other sort of food-related conditions, and that actually people may end up living longer. So I whizzed through that a little bit, but there's plenty more information available online. But in general, we found that children and young people are highly aware of perceived HFS advertising in their local area. They were able to easily describe all the adverts they'd seen, and quite often would just explicitly describe all these adverts and could tell us everything about them. Children and young people were generally supportive of and positive towards changes to HFS advertising, in particular when it was noted that this would be in order to replace this HFSS advertising with healthier alternatives, and they were able to recognise the impacts that may arise from this. So overall, we found that this evidence from the children and young people provided strong support for the policy implementation, and it's actually going to be invaluable in forming this policy that may come in very soon in these areas. However, it's important to note that given the wider exposure that we found from other media inputs and media formats, it's actually really important to consider other exposures that are taking place for these children. And ideally, a policy change in the future, in an ideal world, would be part of a wider suite of measures across multiple media formats. On a slightly different note, we conducted a range of PPI engagement, and this is actually extremely crucial, as we all know, to conducting this research, especially with children and young people, as this meant their voice was really heard and the research was very relevant to them. They could tell us, they informed our research questions, they informed our topic guides, and it just meant that they were really involved in this research. And as always, for conducting research in schools, try to allow plenty of time to do so and flexibility when conducting research with them so that you can work around their time pressures and deadlines that they may have. So, as I mentioned, there is more information available. We've got our slide deck and our reports available online, and there will be papers to follow. And yeah, thank you very much. Sorry, whizzing through that a little bit.
Great, thank you, Samantha. No, and thank you for getting through so much so quickly, so that we've got a little bit of time for questions and comment between now and having a break. So your timing was really spot on there. And personally, I took a lot from that presentation in terms of actually the perspective of the young people, because I think very often these policies are put into practice without that kind of consultation, and I'm always really impressed at how savvy the young people were about the kind of pressures and the issues. So looking at the activity in the chat, there's a specific question from Gabriella about issues around recruiting and overcoming the issues around getting people involved through recruitment of participants.
Yeah, so as I mentioned, we did have trouble recruiting schools. Unfortunately, with the time pressures, that is probably always going to be the case with schools. As I mentioned, you just got to be really, really flexible with them. We were still able to recruit schools across a range of the regions, and by also having the survey, it meant that we were able to incorporate 16 plus and we had quite a bit in that 16 to 18 age gap. So even when we couldn't include them in the focus groups, there was actually findings from them in the survey that came forward as well. We were also still able to speak to children across and young people across a range of areas, including socioeconomic status, which we felt did provide representation. There are things that we would change in that. If possible, we'd have, given that we're doing work in Wales, we in the future would have a Welsh speaker on the team so that we could focus on Welsh schools, as that's not something we could be able to target at the time. And that again would have increased recruitment. But it is just something that you've got to be aware of in schools, is that they have so many time pressures that it can be quite hard to recruit from them. So you've just got to work with them on that.
Yeah, great. There's also interesting question from Chloe about any evidence of age differences, or I guess differences across different classes or different schools in terms of opinions, making the point that different ages, maybe children have different levels of autonomy.
Yeah, so I would say that all the children and young people were equally aware of the advertising, much more so than the adults we spoke to. On a slightly different note, so the adults weren't really able to describe that many adverts they've seen, whereas, as I said, the children and young people, all of them across the board, could really drill down on exactly what they'd seen there. They were also all able to recognise the potential impacts of this policy. It was mainly the much younger children who were the ones that said perhaps that people might still like to actually see some of these adverts around because they can be quite colourful and quite fun. The older pupils didn't really go down that route, but they were all able to recognise the impacts from this and going forward. And yeah, they all were pretty supportive of the intervention overall.
Thanks. Yes. There was one more question about public involvement, the extent to which children and young people were involved more widely in the project, as well as participants in the schools.
Yeah, of course. So I would say it's the youth council group that were more heavily involved. Again, trying to arrange things with schools proved a little difficult. The sessions we ran with the children and young people were absolutely invaluable in the whole process. So we started that really early in the study. I think it was pretty much straight after the Task and Finish group concluded, actually. And we met them initially to talk about the research questions that we can maybe focus on and the actual what the focus of the study should be. We had a proper discussion with them about what direction they felt we should go in. We also, when we settled a little bit more on the study, we spoke to them about again making sure that everything was what they felt was relatable and relevant for them. And then once we put together a bit of a topic guide and some of the study materials, we took it to an in-person session with them and sat down. I think there was about 2 groups of about 10 pupils in each group, if not a bit more. And we actually sat down with them, piloted the topic guide and ran through, find out exactly what they thought about it and made changes accordingly, depending on what they said from that. We had hoped to meet up with them again to discuss dissemination ideas, but unfortunately it didn't quite work out in the end. We're still trying, but they are very, very busy people in demand. But yeah, we just tried to make sure they're involved heavily throughout the entire process. And with the primary school pupils, we actually met up with them to run through a topic guide that we put together. We gave them a bit of an explainer about qualitative research, did a little fun activity with them. And again, we allowed them to give us feedback throughout about what activities they felt we needed, what would make it a bit more fun for them, because obviously it can be a bit boring, can't it, focus groups. So we just tried to make sure that it was really relevant for them, that all the questions made sense. And again, we implemented feedback from that and updated our topic guides accordingly.
Yeah, thanks, Samantha. There are more questions and there's some specific questions, but I promised everybody a break. So what I would suggest is that people who are interested in the details of these evaluations do go and look at the other resources and reports on the website. And obviously, if you have specific questions, you can always get in touch with the FIRST teams to find out a bit more. But I am going to sadly have to be the person who says that we're going to stop and have a break. Great, well, thanks for coming back, everyone. I promised that we would start again at 3, so I'll make it just after 3. So if you're ready to go, Jessica, we've now got Jessica O'Hara talking about the evaluation of the mental health project with children and young people in Central Bedfordshire. Over to you, Jessica.
Perfect. Thanks, Liddy. Yeah, I want to do something a little bit different and start by taking you all back in time to your 16-year-old self. Wanted to ask if you could picture that person, where you were living, maybe who your friends were, what your interests were. And then I wanted to ask if you could start moving forwards in time. So coming forwards to your 25-year-old self. What were you doing at 17? Did anything change? Maybe a move to sixth form or to college, or your first job, or maybe you grew up in care, so transitioned out of being a child in care. How about 18 and 19? Perhaps you started living independently, or starting to learn all that comes with that milestone, or maybe you even moved town or city, or maybe even country. So we're up to 20. What about the ages of between 20 and 25? Perhaps there were some significant changes then. New relationships, maybe starting a career, maybe starting a family, or caring for family members, perhaps. So I think it's safe to say that the ages of 16 to 25 can often be full of changes, full of transitions. So my name is Jessica O'Hara. I am a Senior Research Fellow at First South Bank. I'll be speaking to you today about our evaluation, as Liddy said, of a local government intervention designed to support the mental health needs of young people, particularly looking at that period of life that they may be navigating multiple transitions in that 16 to 25 year age bracket. So we do have apologies from our local government partner who couldn't attend today, But before I begin, I just also wanted to acknowledge that, of course, this evaluation was a big team effort, and I know some others from the team are on the call. So I just invite you, sorry, I've not pre-warned you about this, but if you're able to answer any questions that come up in the chat so we get through as many as possible, any that come up during the presentation, that would be really brilliant. Thank you very much. Right, so you won't need the statistics to tell you this really, but poor mental health has been rising in our young people. We know that there's a range of interconnected risk factors and protective factors that yeah, this won't be the focus of this presentation today, but includes things like childhood attachment, levels of self-esteem, in the family context, that stability or harmony within the family, experiences like bullying, and then the broader kind of socioeconomic factors like standards of living, housing, and enduring stigma to mental health, as well as access to different activities and support services as well. So we've got NHS data, NHS England data here for probable mental disorders. The intervention we evaluated was in England. So this graph on the left shows the changes in time of probable mental disorders across 2 age groups. The first chunk of data is 8 to 16-year-olds, and the second chunk is 17 to 19-year-olds, where each bar there represents a year between 2017 and 2023. As you can see, there's a rise over time in both age groups, and with the most recent data, that's the 2023 data, this graph just splits it up by sex from the age of 8 on the left to the age of 25 on the right. The 3 bars in each group are, as I said, that disaggregated data by sex, where the darker blue bar is the total amount. So you'll see that although the kind of dark blue bars, so the probable mental disorders across age groups are relatively even, I've kind of highlighted a focus on the older age groups, which is where the intervention was focusing, because there are those unique challenges that surround those key life transition points, and also these are particularly important when it comes to support service access and engagement. So that was a picture nationally. Locally in Central Bedfordshire, which is in the east of England, the picture was varied and particularly acute in some areas. So Central Bedfordshire is characterised by pockets of deprivation. This map is of the region, and the darker the colour, the more deprived the area. And you'll probably just be able to just about spot kind of some dark hotspots, which are the areas of highest deprivation. They are amongst the 10 to 20% most deprived in England, and then there are other areas that are around 10 areas in Central Bedfordshire that are amongst the 10 to 20% most deprived in England. So that's one kind of feature in Central Bedfordshire. Another bit of local data is to show that there was a deterioration in some mental health and wellbeing indicators at the time the intervention was being designed. Sadly, this graph shows, from Fingertips data, shows that in the black line, sorry, we've got the England data there, and in the blue line we've got the east of England data, which is where Central Bedfordshire is. The most recent data in the region, you can see that there is a reduction in rates, but as I said, where it's at the time of the intervention was being developed, there'd been a consistent rise in rates above the national average. And then we've got some school data here, school level data from the region, which illustrates a decline in self-reported resilience and happiness. So we've got the examples of the resilience data here. The top one is resilience in primary school age children, and the bottom one, secondary age children there, both showing that decline over time between 2015 and 2023. So Central Bedfordshire took a population kind of data-driven approach to identifying the populations most in need of mental health support, aged 16 to 25, and they supplemented that with qualitative insight from colleagues and also from local young people to identify who may be most in need of that support. So these groups included young people from ethnic minority backgrounds, and young men, people who are LGBTQ+, and young people from socially and economically disadvantaged backgrounds. So the intervention itself, the primary aim reflected this focus on the most in need, whilst also ensuring access for all in need of support. They adopted a multi-stakeholder approach, which resulted in a complex intervention with 4 work streams. The first was a training work stream, which looked at training professionals, including teachers, clinicians, etc. The second was wellbeing navigators. Sorry, that first one, the training, was delivered by the local authority themselves. The wellbeing navigators piece was delivered by Mind in the region. And this was around supporting young people through transitions, whether it be life transitions or service transitions, and connecting them to available support. So that was one-to-one support in community settings delivered by Mind. The third part of the intervention was an educational settings piece, which took a whole school approach to building resilience amongst young people. And the whole school approach is essentially one that embeds mental health and wellbeing into, the breadth of school life, from the curriculum to the broader kind of environment, and it engages stakeholders from the pupils themselves to their parents and the staff and the wider community as well. And the fourth part of the intervention was around building on existing assets in the community through kind of connecting local organisations providing support already. There was an arts focus in this. So there was, for example, a hub with that used theatre therapeutically, and the aim here was to have one of the wellbeing navigators based at each hub. So that was the intervention. When we were first commissioned by NIHR for this evaluation, we worked very closely with the intervention stakeholders to agree a name and objectives. And this, in summary, was to assess the implementation, mechanisms of impact and influence of context on the intervention itself. I know some of us will recognise some of this language. The aims are very much modelled on the Medical Research Council's framework for evaluating complex interventions. In the interest of time, I might not go into too much detail here, but just again to kind of reiterate that we co-developed this evaluation with intervention stakeholders. Part of that was, trying to really understand what the intervention was about, and that resulted in a logic model, which ended up, being the framework for us exploring the aims. Again, there's a fair bit of detail here, but this is just to demonstrate the sort of data collection that we did, data collection for intervention development, delivery, and looking at the lived experiences of people who took part in the interventions. It was a mixed methods intervention, so we did quantitative analysis, looking at service level data. We did an economic analysis, and as I said, we looked at the lived experiences of those involved. We'll just say a little bit more on how we worked with young people in understanding their experiences of the interventions. So we did interviews, but we used a photo elicitation approach. So we essentially, this was asking young people to come to the interviews with an image they could talk about, which essentially kind of shift the power into their hands. And also it kind of provided an anchor where we could come back to during the course of the interview. And the data analysis and synthesis, again, was a mix of quantitative and qualitative to reflect the data collection. I've left one of the most important pieces to last, and that's the kind of arrow that's running along the bottom. We engaged, we worked with a public panel of young people, so a PPIE or Public Patient Involvement and Engagement panel of 16 to 25-year-olds who really supported us right from the beginning of the evaluation, you know, co-developing those evaluation questions right through to kind of informing how we talked about our findings in the latter stages. Okay, so today I'll just be sharing with you kind of three key findings, sorry, from our evaluation. The first one being that overall, the intervention did facilitate greater access to support. Specifically, the training aspect or the upskilling the workforce component of the intervention trained a diverse range of professionals and quite a large number as well, which resulted in more touch points for young people at different transition points. This is quite a nice quote here to illustrate that, you know, those that engaged with the training, it wasn't just kind of an increase in their knowledge, but there was an important psychological impact where people's it felt like there was a boost of confidence amongst staff, which of course is important for supporting delivery of these of mental health support. However, our work also highlighted almost a disconnect between this increase in knowledge, but then the ability to actually implement it. And this particularly, you know, as we've heard from our former presentation, was a challenge in educational settings where the capacity of schools to engage was limited. And then another factor with the potential for facilitating this increased support, access to support, were the favourable costs that we identified in the evaluation, and therefore the potential for the intervention to be scaled up. So the benefits that we observed in the evaluation were compared favourably, essentially to the benchmark that we used, which were a National Institute of Clinical Excellence thresholds for decision making around funding interventions. So those are typically set between 20 and 30,000 pounds, but the cost per engaged participant in this intervention was significantly less. Okay, so our second key finding was that the intervention demonstrated an ability to support readiness for life transitions. Just keep an eye on time. In the interest of time, I've not illustrated the data around you know, the high levels of engagement that led to this. But the table here is illustrating that we observed kind of significant improvements in mental health and well-being factors. And the example here is using a survey called the Dialogue Score, which measures satisfaction across different areas of life, which the young people filled in before and after the intervention. Less important are the grey kind of figures, but just to show that the data was collected before and after the intervention. But the change here is a positive change across all domains of satisfaction. And for those that are, you know, interested in statistics, the effect sizes were all above 1, so that corresponds to a clinically significant change. And for the final key finding, I thought I'd give you a break from my croaking voice and share the animation that the team have produced, which highlights 5 main considerations for improving engagement and reach for those most in need of support. So fingers crossed this works.
Mental health challenges among young people aged 16 to 25 are increasing. We found that interventions are often limited, with a narrow scope or target audience. They don't cater for the diverse complexity of young people's lives and relationships. Working with young people, First South Bank developed key considerations to help you commission services: biographical specificity, storytelling, leveraging lived experience, engaging spaces, layered participation. Let's start with biographical specificity. Often, interventions are developed or designed with a generic focus, but young people will each have unique and specific needs. Interventions are often run in groups, but this may intimidate some young people. They may feel that they don't belong there, or that the groups are not for them.
I was a bit skeptical at first, and I was like, how much time is it going to take out my schedule? Is it going to be a hassle? Am I going to have to pay for it? Which was a big thing.
We need to relate to young people's everyday contexts. By naming certain issues, young people will see their own situation reflected and be more likely to access the services. So, to consider specificity, don't ask what's wrong with me, ask what's happened to me and what is happening now. Storytelling. Young people's stories offer so much more than just numbers and labels, but they don't feel their voices are truly heard. The young people I've worked with stories are their own, and they want to share that, but they've not got a platform or a space in which to do so. We need to empower young people to tell their own rich stories. To do this, interventions should involve multiple perspectives, including those who are seldom heard in mental health spaces, rather than just relying on outcomes as a measure of success. This will help bring alive the complexities of the challenges they face. Policymakers should consider storytelling because it's insightful and powerful. Life is messy, so look beyond the clinical labels. Lived experience. We know those suffering with mental health challenges can feel very isolated, but developing relationships with peers experiencing similar challenges can be a vital support.
I thought I was the only person having that issue, but there were a lot of people having the same issues.
The expertise of people with lived experience of mental health challenges goes beyond support that may come from family, friends, and professionals.
I was so glad. I was happy I have someone who can actually call me to check up on how I'm feeling.
We need to recognise peer support as a valid intervention in its own right. Local government can build on and offer support and training to those with lived experience so they can help others. Lived experience offers a perspective that cannot be replicated. It's a unique and invaluable resource. Use my expertise, but support me. Value my contribution. Engaging spaces. We need spaces that invite young people in. If you don't empower young people or help them feel relaxed, they're unlikely to engage or open up.
I was like, are they going to hate me? Are they going to laugh at me for who I am? I don't want to be there. That was in my head.
Some schools have tried to establish well-being spaces, but young people found these were too formal and clinical, and often space was in high demand. Finding and providing appropriate spaces will allow a relationship to flourish between the young person and those offering the intervention, and lead to improvements in mental health for young people. When it comes to engaging spaces, think relaxed, accessible, friendly. Don't box me in. Our final consideration is to offer layered participation. Many young people may be reluctant to engage initially, so before any interventions are offered, we need a personalised meeting with the young person. We should manage their expectations of what's to come, find out their concerns about participating, and the meaning behind their distress, without putting them on the spot. By giving them control over their own level of participation, we can avoid young people not engaging.
On my first day, I told them no, I'm not using the microphone because of some of the questions they were sharing.
Create layered participation by getting to know me, not the label I have. So, in summary, when developing interventions, our 5 key considerations are: prioritise biographical specificity over labels. Young people's stories matter. Let them tell them in their own words. Value those with lived experience and what support they can offer. Enable young people to chat about their expectations, fears, and dreams in an informal space. Start with a getting to know you session to hear their story. By following these considerations and accepting that it's the complex stuff that needs the time and space to be explored, we can reframe our services to meet all young people's mental health needs better.
Perfect. I appreciate that didn't work for some people, but hopefully you've got a hold of the link to have a look at that later. I've skipped a couple of slides, but I think they will be available for you to have a look at as well. So straight on to our conclusions. Yeah, our evaluation adds to the body of evidence that articulates the key components of interventions like this that can support young people, particularly at transition points. I'd titled this talk Transition Points, Gaps and Opportunities, and we identified 3 main opportunities for policy and practice. The first one was around policy frameworks considering extending the whole school approach to other educational settings. The second was around considering those 5 key recommendations shown in the video in a context sensitive manner to strengthen community-based interventions, because these community-based interventions are of particular importance for young people who might be disengaged from school, or those that might not just typically engage with traditional services due to stigma or mistrust or fear. And then the third one is around considering building on the model that Central Bedfordshire worked with, which was working with young people to co-design the intervention. When we'd interviewed these young people, they actually recognised aspects of their contributions in the intervention, which we in turn, demonstrated as having a level of impact. So that was really great. But we've found that it's important that this is an iterative process and perhaps part of an evaluation of the intervention itself, where those lived experiences of the young people provide insight into not just what's working or not working, but how and the why. So yeah, their insights have the potential to really shape decision making and service redesign and commissioning. So that was it. Yeah, I've been on a journey. Individually, you've kind of reflected on your transitions during 16 to 25 years old, and together we've kind of explored those considerations from our evaluation around developing interventions to support young people through those transitions during that age bracket. Thank you very much, and thanks, Liddy, for the timely popping up to remind me to end.
Thank you, Jessica. That was fantastic. And in the chat, you'll see there's been lots of love and appreciation of the animation in particular. And also, I have to congratulate Susie and Patrick on the team with the teamwork, because while you were presenting, Patrick and Susie were addressing some of the specific queries in the chat. Now, I think as chair, I'm going to have to formally end this webinar at 3:30. But as far as I'm aware, I don't think there's any problem with people actually staying on the link if there's time for people to put in a few more comments. But to ensure that we can share the things that we wanted to share at the end, I will go back to sharing my slides, if that's okay. So I just promised that at the very end of the webinar, I would remind you again that there is a call for expressions of interest from essentially anybody who is involved in or aware of an intervention being commissioned or delivered by local authorities that meets the first criteria. There's a link there. It's all on the website, and I'll highlight the fact that if you want to find out a bit more about the programme in general, there is a webinar talking about what's required in terms of applying to have your own local practice evaluated, if you're inspired by today. And also, I was asked to flag up that at the Local Government Association conference that some people may be involved in this year. It's coming up at the beginning of July, and first we'll be there. We've got a fringe event which is being led by our first colleagues and the Liverpool Director of Public Health, Mark Ashton, to talk about evaluation and first. So that's something that you may be interested in yourselves or like to flag up to any colleagues who are involved in the LGA conference this year. And just finally, do keep in touch. This webinar is one of a series. There is lots of information that's always being added to on our first website, and there's a mailing list that ensures that you will be the first to know about any of these events. Now, as I say, sadly, I'm going to have to formally end the webinar, and I realise people will have other things and meetings that they need to move on to. Now it's 3:30, but hopefully everybody's learned something. I've certainly learned a great deal, and would just say thank you very much to all our presenters, all our contributors, and everybody for coming along. So thank you for now.